This podcast represents my opinion and the opinion of my guests. This is not medical advice, and I am not establishing a patient-physician relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only. And because each patient is so unique, please consult your healthcare professional for any medical questions you may have.
Welcome back, everyone, to the Not Your Doc podcast. I'm your host, Vanessa, here with our producer, Seth, and we're back again with Dr. Tadros, Mr. Not Your Doc himself. How's it going, Tadros?
Hey, hi, everybody. Thank you. Yes.
So this is the promised part 2 of our discussion on hospice and end-of-life care. So we are actually going to continue to resist the urge to look away from this difficult issue. And we're going to lean into something that makes us uncomfortable for a little while because I think we're going to be much better off after doing that. And we're going to talk specifically about the dying process. And, you know, I feel like this is an important part of our podcast in general, that we try to talk about topics that people don't necessarily want to talk about. As Dr. Tadros likes to say, this is the shit no one talks about, because no one likes to talk about these thorny issues. They make us uncomfortable. They make us recoil. We feel like it's morbid. But really, we see, I think, in a lot of our patients that come through the ketamine clinic could have benefited from more open and honest discussion about hard things, right?
Yes, sorts of things, not just...
all sorts of stuff, right, exactly. So we're going to continue to push through both for, ourselves and for anyone who's listening to this, so that we can all be more prepared to, address the time in life that we're all going to face. So
thank you. Yeah.
So now we're going to learn some more specifics from Dr. Tadros about what life looks like in its final months, weeks, and days for a dying patient. So before we get into the booklet that we referenced last time, Dr. Tadros, can you talk a little bit more about your personal experience with hospice? Like, why did you want to do hospice? Do you find it morbid? Can you talk about what having a good death looks like for you?
Well, in these times, it's weird because people are looking at longevity. I love to listen to everything from podcasts, and I follow several people that are doing longevity research. So this is extending people's lives beyond the 70s and 80s and 90s. So that's one aspect of it. And hopefully there's also a health benefit. You just don't live longer, but you're also healthier while you live longer. In the end, we're all going to pass away one way or the other, just like plants and animals and a lot of things in our immediate world. We're going to pass away. Hopefully it's far down the line, and hopefully it's a full life with no disability, no pain, no suffering, and a quick death. And this is, believe it or not, this is kind of what we believe a good death is, among other things, is that unhampered long life. And a relatively painless death with people that love you around you. So that's one way of describing what a good death is. Everybody describes what they want their own way. But the other, I talk to people that pain and suffering are two different things. They're often related. Pain could be physical and emotional, spiritual pain. Suffering is kind of this existential angst about being afraid, being not sure about the future, being alone, or not being maybe around people, but not the people that you wanted to be around. So that's type of suffering, of people not believing you or ignoring you, not being noticed. That's the type of suffering. We can help with hospice and other things that we do in the medical profession. We could help with pain and suffering. And there's spiritual practices have been doing this for thousands of years before we had PET scans and CRISPR technology.
Right, absolutely. Yeah, I think that's a very, it kind of comes back to everything that we talk about here. What we do at the clinic, it's about giving people dignity, right? In their most challenging moments, in the midst of their struggles, and also just, having empathy and compassion relating to others.
Very
because because, if you're a hospice patient or a family member of someone who's in hospice, you're in a very vulnerable moment of life. And it's our duty in this helping profession to, help people not feel alone and trapped in those moments. So, will you go ahead and introduce us to the booklet you're going to be referencing today, and tell us a little bit, like, what's the purpose of providing something like this to patients and families?
Well, anytime we talk to anybody, I don't care if you're talking about life insurance, about how expensive your car repair is going to be, you're not going to hear everything.
Right.
So that's part of it. So it's written down and handed. This is as part of a packet of stuff of information that we give patients and their loved ones to keep at the bedside or near the refrigerator or on the way out the door, so that they have our hospice information, our contact information. So instead of calling 911, you're calling the nurse on call about any symptoms or any questions and stuff like that. So, but also this is part of almost every hospice I know has this type of written information about physical, emotional issues that may happen weeks to months to hours before dying.
Yeah, it's kind of the what to expect when you're expecting of death.
Of death,
yeah.
Yes. As opposed for babies.
For babies, yeah, sure.
This one is entitled Gone From My Sight, The Dying Experience by Barbara Carnes, Karnesrn. And I think it's written simply and pretty complete. Yeah. We talk about potentially the dying process starting 1 to 3 months prior to death. Now, you have to be very flexible about how things happen, right? How your brain and your body respond and the situation, physical and emotional situation you're in, will alter everything. But generally, this is some of these words and some of these concepts are going to happen to a lot of people. Sometimes they happen over small periods of time. Sometimes they happen over hours and minutes. And sometimes some of these will happen for much, much longer.
Could you give an example of a patient with like a specific type of diagnosis who might be looking at a 3-month prior to their death kind of thing?
Yeah. So somebody who's cancer, once again, hospice was started really for cancer patients many decades ago, but it includes a lot of diagnoses like I've mentioned before, end-stage HIV, end-stage liver disease, there's oftentimes cirrhosis, end-stage brain issues like dementias and after bad strokes or multiple bad strokes, kidney failure, been on dialysis, heart disease, heart attack, heart failure, and cancer. So I'll pretend it's a cancer patient.
Sure.
Let's pretend it's a colon cancer. It's metastatic. That's no longer treatable because treatments, despite treatments, it's the cancer cells have added into lymph nodes and into the liver and now are in the bone. So this type of let's pretend like this.
Has the typical person here, let's take our example patient, have they been going through treatment for a while? They've tried lots of different things. They've had lots of tests. They have not.
Months to years.
Have they received a prognosis before this point?
Right. So a lot of patients, unless it's very advanced cancer when it's first found, a lot of patients may not be told the prognosis, the end of time prognosis. They may just say the prognosis, what the prognosis of this type of chemo that we're going to give you or the surgery.
Okay.
So they may tell you what the next few days, weeks, months we're going to, for what we're trying to do. They may not be told that 80% of these people will not survive 5 years. That might not be the first few conversations.
Yeah.
So oftentimes what will happen is that unless the physician wants to reveal a lot of stuff at once, or unless the patient or family wants to know a lot of stuff up front, a lot of what we'll talk about is the immediate, that'll take up your brain space, your immediate testing and immediate specialists and all the driving and the insurance issues and all that stuff will take up all your brain space.
Yeah.
And then after you've tried multiple things and they've worked for a while and then the cancer came back or et cetera, then down the line, people will start hinting that maybe for this third type of chemo that we're going to try on you, now we see new spots on your brain.
Yeah.
What used to be in your bone and your lymphatic and your liver, and starting in your colon, now it's in your brain, potentially in your brain. We probably don't want to do a brain biopsy. Let's just give you another type of chemo, and if that doesn't, if the CAT scan or MRI or PET scan doesn't change, maybe then we'll start hinting that we're running out of stuff to help you. Maybe hospice is appropriate.
Yeah. Wow, that must be So that's kind of where we're meeting our patient, right? And their family when we're talking about these
That's right.
1 to 3 months prior to death.
That's right. So 1 to 3 months, the patient may start withdrawing, and kind of recognizing that they're more tired, that reality is kind of settling in, so that they're emotionally kind of withdrawing. They're not as loquacious, they're not as talkative. They may not want to see loved ones and relatives. They may not have energy to sit very long at a party, or want to go to a party at all, or even a movie. And so they're kind of going within into themselves. So that's part of that. Just sitting with them may be the best that you can do, coming to be present.
Yeah. What about physical touch?
Yes. And so a lot of people, physical touch, and it depends, it's biblical, et cetera, right. Whether you're washing somebody's hair or putting on a lotion, all that stuff actually
anointing
counts.
them with oil.
That's right. It is. It's your version of anointing with oil. So all these actions are extremely important and comforting for most of us. Now, some people touch, if you have fibromyalgia, or if you have metastatic bone disease everywhere, it may hurt to be even some of the gentle touches. Or if they're feverish, so sometimes. So at the bedside, this is where relatives and nurses, and nurse aides and other people will start to, after you've known the person for a while, you'll start kind of getting the rhythm of they sleep here and they're awake here, and they'd rather talk for 5 minutes here, but not 15, and all that stuff matters.
Sure. Okay. Yeah, that's great.
So also starting at 1 to 3 months before, depending, even whether it's kidney failure, with dialysis, heart failure, lung failure being emphysema, cancers, these people, appetite may go down. Their taste of food, the textures may not be appealing, the smells may not be appealing. They may lose their sense of taste, so that the typical flavors don't taste right, or they taste metallic. And they just don't eat as much. They may get full faster. They may feel hungry, but within a few bites, they get full fast. So all that stuff, when a lot of us are like, you got to eat, blah, blah,
absolutely.
blah.
I can imagine that'd be super alarming for a loved one or a caregiver.
It is. It's one of the most distressing things to see a wife, and it brings tears to my eyes, who's 76, and her 80-year-old husband is not wanting to eat, but for the last 60 years, she's cooked and stuff like that. He's loved her food, and the grandkids around food, and the kids and the birthday parties. All of a sudden, he doesn't want his favorite meal anymore. Yeah.
Yes, that is.
Sometimes it can suck down liquids. So sometimes something cold, something soft and cold. So the textures may be fine. Something super sweet or super salty. Sometimes it's still palatable. Not always. Oftentimes the harder stuff to digest is tough to chew. Like meats and fibrous vegetables are some of the first ones that people just don't tolerate, don't want, and stuff like that. This is a normal part of kind of your body starting to withdraw from life, essentially.
Yeah. So it's not, people and caregivers don't need to feel, it's okay not to eat, right?
Guilt, right.
I mean,
you're still a good caregiver. You're still a good loved one. It's just you can't provide the stuff that you used to be able to provide, and they appreciate it. They can't appreciate it as much. The equivalent of what I tell people is, if you and I had the stomach flu, putting food in front of me whenever I'm puking and having diarrhea and don't get out of bed is a loving gesture, but it's not what my body is going to accept.
Sure. This is certainly an opportunity to explore different expressions of love languages and ways of comforting. That's very interesting. Okay. So anything else for the 1 to 3 months? I mean, you said people aren't going to be as communicative. They're not really going to want to talk as much. So
they don't want to go out. They may not want to see their friends or grandkids as much. Or they get tired more easily. Sometimes more frustrated with themselves and maybe with other people. So it's always a challenge to the social aspect of people coming by and knowing that you're terminal, you're on hospice, you're 1 to 3 months away, your 6-month prognosis before that you may die. It's not automatic, but you may die, and people trying to come see you, but you're already kind of don't want to see them.
Sure. It's interesting because I'm thinking now that we're going through this, that sometimes we think when we know a loved one is dying or someone is very sick or we don't have many opportunities to see them anymore, it can become more about us.
That's right.
And my desire to see you one more time,
That's right.
or my desire to hash things out one last
That's
time
right.
and put our differences to bed or whatever. But it actually might be more a more humane and a more dignified gesture for me to just meet that person where they're at. And if
That's right.
they don't want visitors, to respect that
Right.
and to let, unsaid things go unsaid, perhaps.
I segregate the patient from the family. Sometimes the family wants the casseroles. Sometimes the family wants the relief by sitting in the back porch and talking for an hour and a half.
Sure, yeah.
So the family may be accepting and appreciative, but the patient may have already crossed over to the I'm too exhausted about life.
Yeah.
Yeah. And this is a reminder, and also brings tears to my eyes, of why we need to take care of shit every single day, because you never know when
Exactly.
this level. Now here's hospice and we have time, but they may not, just because they're on hospice doesn't mean that you're gonna feel great until the last part of the 6 months and then pass away. So they may start, some people, whenever we put them on hospice, or pass away within a few hours of coming to see them. Some people will last a couple of years in hospice, and we can talk about why it can be a couple of years. But typically that's why we say 6 months. So I tell people, any chance you get to say hi to people, love them,
absolutely.
go see them,
Yep.
you pick up the phone, FaceTime them, it's better to do it now.
Resolve differences, go to therapy together.
Better do it now than whenever you don't know when the end is coming. So.
Absolutely. Wow, that's powerful. Okay. What about 1 to 2 weeks?
Yeah, so the 1 to 2 week mark. So we're getting down. Whether it's in this case, we were talking about cancer. It could be heart failure. It could be stopping dialysis from your kidney failure, et cetera. But 1 to 2 weeks before death, sometimes we'll call this actively dying. You say, what do you mean actively dying? Well, sometimes they become more disoriented. So this is kind of the delirium or terminal delirium that they'll sometimes, or they'll become more confused. They're sleeping a lot more. They may start talking to long deceased loved ones, so they're confused and they're talking to people who passed away. They're picking at their bedclothes and they're agitated. Their arms are moving and stuff like that. So it's hard to see somebody who used to be smart and bright and stuff like that all of a sudden become sleepier, more disoriented, etc. And you can't communicate with them, even though they may be awake.
Right.
You may not be able to. They may not be able to follow instructions as easily.
So before we delve more deeply into that,
Sure.
the 1 to 3 month stuff that we're talking about, conceivably a person could live like that for a long time.
For a long time, that's
right?
correct. That's correct. Yeah, people. We have people on service that are in the 70 or 80 pounds, and they've been with us for many months at that level. You say, how much? Where are they getting their calories? They've gone through their fat stores and glycogen stores, and now they're dipping into their muscle stores. Muscles as being broken down, and stuff like that for energy. So yeah, people can last much longer than what the Bible says, without food and without water, all sorts of stuff like that. Yeah.
Yeah, absolutely. Okay, so then, but the delirium and this 1 to 2 weeks prior to death is pretty much everyone's gonna get to this stage and approach it.
Right. So delirium, and from our past talks, there's a hyperactive delirium, hypoactive delirium, and mixed delirium. Delirium is just kind of a confused state.
Okay. Yeah.
It could be because of low oxygen. It could be because of metabolic waste products are piling up in the bloodstream. It could be because they're constipated, because they're infected. There's a bunch of reasons to become delirious. But people are starting to call this some of the terminal agitation, terminal delirium. Sometimes it becomes worse before it becomes better. And we could talk about that, but anyway. But that's the disorientation, and part of it is the delirium. 1 to 2 weeks prior to death.
Sure, it's kind of just sort of losing their bearings and
correct.
their grounding.
Your brain may not be getting enough oxygen, enough blood flow. There may be metabolic waste products that are piling up in your body from your kidneys not working, your liver not working. Yeah.
And because you've stopped dialysis and all other medications and stuff, that's kind of a natural progression of those diseases. Okay, great.
So once again, it's still the 1 to 2 weeks before. There's physical changes. Blood pressure may start lowering, even if they've had long-standing hypertension. You have to start stopping or stopping their blood pressure medicines, backing off because you want to get blood flow to their brain and to their legs. So sometimes your blood pressure medicines that help control your blood pressure before, now you're no longer needed. Your heartbeat can increase or can potentially drop. Your body temperature is hard to regulate. You may become sweaty to chilled. You can have increased perspiration, kind of cold sweats, clamminess. Skin color could be flush with kind of whenever your blood vessels dilate on your skin, they become flush and you kind of feel hot to the skin or feverish, or you become cool and pale as your blood vessels clamp off blood flow, try to keep it in the middle of the body, so they clamp off peripheral blood flow, so you get mottled and bluish fingertips and toes. So that's some of the signs that your autonomic nervous system is starting to
that it can't maintain its homeostasis anymore, right? Okay.
This is all automatic. Blood pressure, heart rate, perspiration, temperature, skin color, all kind of part of under the direction of autonomic.
Autonomic meaning we don't consciously tell our body to do these things.
Sympathetic and parasympathetic nervous system. That's right. Breathing changes where you can have everything from some small pauses, rapid breathing, then pauses, sometimes bigger pauses. Congestion, you start rattling. It can be in the throat, which is kind of mucus from your mouth and drainage from your nose.
Why congestion? If you're not getting a lot of fluid intake, and why does that happen?
Yeah, so our body is about 60% fluid. Total body is 60% fluid. So you can start shifting fluids from inside the blood vessels out of the blood vessels into soft tissue, and soft tissue could be into your lungs and your throat, etc.
Okay.
We still are potentially still making saliva, and so if we don't swallow it into our stomach, it sits in the back of our throat, and as you breathe, it rattles.
Okay. Yeah.
So so that's and sometimes you'll cough. Sometimes it'll be a dry cough. It's not bringing up anything. Sometimes you can clear the rattle temporarily. Yeah. And then we were down to the last couple of days to a few hours beforehand. And by the way, what I like about Nurse Karn's booklet is that I do tell people, months to weeks to months, years to months, weeks to months, hours to days, and minutes. So I tend not to say, you got 6 months to live. I say, roughly. We're in the months. We're in the few months range. We're not into the multi-year range. Before potentially passing away.
Before the last couple of days, I know like they might be sleeping a lot, but are they still responsive?
They can
typically
be. Right.
Okay.
They can be.
They can be. Okay.
The problem is with delirium is that they sometimes will make sense, and sometimes they'll wake up if you shake them, and they make sense, but then they drop off asleep right away, and you rattle them and you ask them what they want because you just had to awaken them and they don't remember speaking with you. So that's the frustrating problem.
Yeah.
They may be awakened with stimulation, and they may respond, but they may not remember what they said or what you said.
Okay.
Yeah.
And can't announce their needs or
that's right.
that sort of thing. Okay.
Yep, they can't express their needs. There's a big problem on its own. So you start having to interpret: are they in pain because they're wincing or grimacing?
Yeah,
all that stuff. So 1 to 2 days before, 1 to 2 days to a couple of hours before death, there may be a pump up, a surge of energy. They may talk clearly. They may all of a sudden, after days and weeks of not wanting to eat, they'll actually eat. They may sit up in the living room and talk to relatives and stuff like that. So all of a sudden you think like things have already turned the corner. We're back. And the answer is that sometimes it's just hours to a couple of days before you pass away that you have the surge of energy. Yeah. So these people eventually, after the surge of energy, they become restless, which is also part of terminal delirium. I like to remind, whenever we talk with medical students, whenever you have lower blood oxygen level, you become more agitated. If you have increased carbon dioxide in your blood, like emphysema patients, you become more sleepy. So sometimes that's a sign that
their agitation is because your body's fighting for more oxygen.
Potentially,
it's trying to get you to
lower blood flow with oxygen or lower oxygen in the blood that is getting to your brain. That's part of it. These people are starting to accumulating waste products. Remember, whenever we typically we get rid of waste products in our breath, carbon dioxide, through a little bit through our sweats and through our urine and through our feces. So as things start shutting down, these tend to accumulate in your soft tissue and your bloodstream.
It's not being excreted. That makes sense.
Days to hours before, a surge of energy, then you become restless. Breathing patterns become slower, irregular, sometimes apnea, stop breathing for long periods of time. Congestion can be loud. This is the death rattle that people talk about. So it could be in the lungs, but oftentimes it's just in the upper airways, in the throat. Eyes may be fully closed, but if they're open, they're kind of glassy. They're not focusing on stuff like that. Oftentimes they'll be pale, they'll be cool, they'll be gray. The hands or feet may become purplish. And now the autonomic nervous system if it's partly working, will sometimes clamp off the blood flow to your limbs so they can keep you alive, keep your blood pressure elevated. So to your brain and your heart and your kidneys, but it's being ineffective in doing so. And then the patient become comatose or non-responsive, and sometimes when we'll have their face will be sunken, their mouth will, your ability to hold your jaw shut, keep your lips closed is gone. So your mouth gapes, and sometimes it looks like a circle or an O. And some people will start the last few seconds, minutes, they'll start looking like a goldfish, kind of looking like trying to gulp air. They're unconscious, but it looks like they're trying to gulp air with their mouth, that's usually seconds to minutes or less away from stopping breathing.
Wow. How long can that process last? I mean, days or hours? Are we talking like up to 7 days or up to 2 weeks living like this? Or?
Yeah, typically we're just 1, 2, 3 days. We're down to oftentimes not even. Sometimes once you're kind of glassy eyed and you're you have apneic pauses, these breathing pauses. Sometimes you're just minutes to hours away. Yeah.
Wow. So there is a really great poem in here, and there's also some great metaphorical language that she uses in this booklet that I like. She says, the separation from, the person from their body becomes complete when the breathing stops. The owner is no longer in need of a heavy, non-functioning vehicle, and then they enter a new city and a new life. I think that's kind of a beautiful way to think about it.
Yes.
I know sometimes that people lose control of their bowels, and
yes, my father did.
Is that something that happens after the time of death or at the time of death?
It could be right before, shortly, a few minutes to right at the time of death. My father didn't want to go to the bedside commode in his chair. He was dying of heart failure. He didn't want to go to the commode. I'm sure he was confused at the time. So I carried him. He was probably 85 pounds. I was carrying him to the toilet and they will feel like they have to go and stuff like that. It's interesting. They'll feel like they have to pee, but he said, you have a catheter in you. Or I have to go and stuff like that. So they don't, so their sensations are distorted. I carried him, and on the way back from the toilet to the bedroom, he just kind of went limp in my arms, and I kind of walked the last few steps and put him under the covers, and he defecated and urinated under the covers and stuff like that. But yes, that's kind of the last as your nervous system that controls your bladder and your colon and defecation, urination, and defecation. They kind of let go.
Yeah. Wow. So, I mean, that's kind of what it looks like. What happens after a person passes as far as hospice care? How does the care conclude? How is there more support for the family still available?
Yeah. So first of all, if it's at home, and oftentimes the nurse is not there, the nurse or the nurse aide, and so the hospice team oftentimes is only there a handful of hours per week between the pastor and the social worker and the nurse aide who helps with the baths and the nurse who does the medication and wound care and stuff like that. They may only be there between all of them. They may only be there, 3, 4, 6 hours a week total between all of them. And so there's nobody there this overnight so oftentimes the patient will pass away with the relatives or at a nursing home without the immediate professional team right next to them. So that's the first thing. So no need. Some districts in some areas in the country, you still have to call 911, even if they're on hospice. But usually we help you understand in your district if you still need to call 911 to be declared deceased. But
that's interesting.
typically, this is the service that the hospice provides. You call the hospice nurse if the person is in distress or the person has just passed away. You wake up and they've passed away, and the nurse comes and declares them death. Calls the coroner's office. The coroner. Every municipality has a process. The city or the state has a process to help know who passed away.
Sure.
If there's suspicious circumstances or because of accidents, the coroner has to be made aware and stuff like that. So so the nurse typically, and there's usually this already in the packet that's been given to the family. There's a funeral home that the family of the patient have selected,
chosen,
and that helps. So all these people help. The nurse will help. The funeral home, even if they die out of state. Funeral home is the way where they go, and they're kept until they put on a plane or whatever to go back. So all this stuff can be taken care of in advance with just a little bit of information and keeping the information on a file next to the phone, etc. So yeah, it's people. It's almost every funeral home, crematorium that we've worked with has just been beyond fabulous.
Yeah.
Wonderful people.
That's wonderful. So, to kind of conclude, what do you want our listeners to take away from this conversation?
Sure. It could be morbid, but it also could be mechanics, checklisty.
Sure. Yeah.
Obviously,
it's both. I think it's both.
In a lot of ways, it's
right?
both. Yeah. But it can be less frightening if you kind of know what's happening and who to your resources, the people that you. So it's not an emergency. It's in the middle of the night. You're not calling 911 with a bunch of sirens for somebody that has been dying for 6 months.
Sure.
That all of a sudden is it's a big shock to the system. Yeah. It's an important. It's a reminder for me as a physician, but for us to review our lives now. Am I living the way I want to live?
Yeah.
Am I around the people I want to be around? Am I doing what I think is important? So that way, we with regret decrease our level of regret. That's the first thing. The next thing is to be able to write down or tell people, not just write down, but tell people that love you and stuff like that. This is what I want, or this is what I don't want, and write it down. If it doesn't always have to be professional, notarized, whatever. So the typical documents are healthcare power of attorney. So somebody who takes care of you, who steps in your shoes and speaks for you if you're not able to speak for yourself. You're still alive, or but you can't make decisions. So it's healthcare power of attorney or power of attorney in this case. There's a financial power of attorney and stuff. It could be the same person. Oftentimes it's a relative. Sometimes you can pick an attorney to be your healthcare if you don't have any relatives. So that's do not resuscitate. To decide what you're going to sign it or not sign it, and what level of do not resuscitate. You can intubate me, but if I need dialysis and antibiotics, I don't want that. So you can do that level of stuff, and then understand, put your stuff in order, whether it's your paperwork for your finances or your gun collection, who you're going to give it away for, and stuff like that. Your will, and then you can focus on the stuff that matters to you the last few days, weeks, months of life. I think that's kind of the most ideal way. Not everybody does that, obviously.
Sure.
So that's the most ideal way, and then. All the while as part of your spirituality, whether it's organized religion that helps you understand why now, what happens after this. And certainly, as we know, that we say that the people who pass away don't have any more worries. It's the people who are left behind that are grieving and the what ifs and the sadness and stuff like that. So there's bereavement is what you're alluding to. So we have all hospice provides bereavement up to a year. Sometimes even before somebody passes away, there's so much grief that bereavement starts even before for the loved ones, the survivors or the loved ones. So the bereavement is a big aspect of, and there's even bereavement for youngsters. So if their mom or their uncle or cousin pass away, there's bereavement for youngsters.
And those are services to support the grieving process,
That's right.
to help process
That's right. And it could be started before the person actually passes away. That's right.
Wow, yeah. Okay, well, thank you, Dr. Tadros, for sharing this with us and being vulnerable about your experiences. Sure. And I think, once again, one of our goals is to demystify, right? And as you said, that, sometimes just knowing the mechanics, knowing some of the particulars makes things a little bit less scary. And kind of understanding how this process plays out, it gives me a sense of comfort too. I mean, I have grandparents who are elderly, and I've had, friends' parents who have passed, and, we're all going to experience some of these things at one point, if not
for
ourselves, at least for people that we know and love and care about.
And we can help other people. If we know a little bit about this, we can help other people know what should be out there, or they can potentially ask better questions, et cetera. Yeah, absolutely. I never have problems with people writing down questions and sending them to us.
Yeah.
I always love my patients. I don't care if they got it from the internet or their friend's friend. I'm always interested in hearing how people think and what they hear. It forces me to double check my work and my assumptions and the stuff I learned and what I say. So, yeah.
Sure. So to that end, if you have any questions or feedback for us, please send it to our email address at notyourdocpod@gmail.com. And we would love to take a look at that. Of course, our podcast is available on YouTube, Spotify, and at our website, notyourdoc.com. There you can find all of our episodes, as well as a link to Dr. Tadros's blog, which has many more beautiful thoughts about all kinds of different things. And we'll continue mining it for the next 20 years for content for this podcast. So
that's very nice of you.
So thank you again, for myself, for producer Seth, for Dr. Tadros. We will see you again.
Thank you. This previous podcast represents my opinions and the opinions of my guests. This is not medical advice, and I'm not establishing a physician-patient relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only, and because each patient is so unique, please consult your healthcare professional for any medical questions that you may have.